Welcome back to the deep dive. If you're like us, you've been watching this, revolution happening in treating type 2 diabetes and obesity. These drugs, semaglutide, tirzepatide, they're not just about blood sugar anymore. We're talking fundamental changes to cardiovascular risk. Yeah, it's huge. And we know from the big clinical trials, the RCTs, that these GLP-1s and the dual agonists, they definitely cut down major cardiovascular events, heart attacks, strokes. But here's the snag, right? The reason we're doing this deep dive today, we don't actually have a big head-to-head trial comparing semaglutide directly against tirzepatide for those hard outcomes. And honestly, we probably won't get one.
Exactly. And that leaves everyone, clinicians, you listening in, trying to compare apples and oranges from separate studies. Different people, different rules for who got in. It's messy. So our mission today is to clear some of that up. We're looking at a really large, very carefully done study using real-world evidence, think massive databases. And they aim to create that missing direct comparison. How do these drugs stack up in typical day-to-day practice? They focus specifically on MACE, major adverse cardiovascular events, that's the big one, heart attack, stroke, or dying from any cause. It's really the key measure for cardiovascular benefit.
Okay, let's get into the methodology, because whenever real-world evidence, or RWE, comes up, people get skeptical. And for good reason. Real-world data isn't clean like an RCT. You've got bias, all sorts of confounding factors. It's inherently, messy.
Oh, absolutely. That skepticism is totally fair. And these researchers knew it. Their whole strategy was built around addressing that distrust. They used something called trial emulation analysis as part of a larger effort, RCT duplicate. They pulled data from enormous U.S. claims databases, Medicare, Optum, Market Scan, covering several years, like 2018 up towards 2025.
Trial emulation. So trying to mimic a clinical trial using this real-world data, how did they actually prove their data wasn't, garbage in, garbage out?
That's the clever part. They started with benchmarking. Before even attempting the new comparison, they essentially went back in time and tried to recreate the results of two major, already published RCTs. Specifically, SUSTAIN-6 for semaglutide and SURPASS-CVOT for tirzepatide. The idea was, if their real-world setup could match the findings of those gold standard trials, then they could trust their method.
Okay, that's a smart way to build confidence. Did it work? Did their real-world numbers line up with the published RCTs?
They lined up remarkably well, actually. So when they emulated semaglutide against sitagliptin kind of acts as a stand-in for placebo in these RWE studies, a risk reduction they found, very close to the original SUSTAIN-6 trial result.
Nice.
Same thing for tirzepatide. They emulated its trial against dulaglutide, and again, high agreement with the SURPASS-CVOT findings. So overall, great validation for their framework.
And I sense a but coming.
There is a but. And it's actually crucial because it shows how careful they were. During that semaglutide benchmarking against SUSTAIN-6, they found something interesting. While the heart attack and stroke outcomes matched up well, the results for all-cause mortality, just death from any reason, were quite different from the original trial.
Whoa, okay, so the death numbers didn't align. Why not? That sounds like a problem.
It signaled what we call residual confounding. Basically, their real-world model couldn't fully adjust for all the reasons why certain patients starting the comparator drug, sitagliptin, might have been more likely to die anyway. Maybe they were sicker to begin with, And because they couldn't fully explain that difference in mortality, they made a really important call. They decided they couldn't fully trust the mortality data in that specific comparison going forward.
So rather than just push ahead or scrap everything, they adjusted their plan based on what the benchmarking told them?
Precisely. For the main expanded semaglutide analysis that followed, they actually removed death from the composite outcome. They focused only on MI or stroke for that comparison, the parts where their benchmarking showed solid agreement.
That level of caution is actually really reassuring. It shows they weren't just trying to find a result, but were critical of their own data.
Exactly. It's a great example of how you make RWE rigorous. You test it against the gold standard, and you adapt when needed.
Okay, that methodological rigor is key. So let's move on. They established their approach, then they looked at broader populations, right? The kind of patients doctors see every day, not just the high-risk ones in trials. How did these newer drugs perform against the older options in this wider group? Let's start with semaglutide versus sitagliptin.
Right, so focusing just on that adjusted endpoint myocardial infarction or stroke, semaglutide showed a clear benefit compared to sitagliptin. The hazard ratio was 0.82, statistically significant. It means about an 18% lower risk.
So the heart protection holds up in the real world in a more general population. Good to know. What about tirzepatide?
For tirzepatide, they compared it against dulaglutide, which is another established GLP-1, And here, because their benchmarking for tirzepatide did align well, even for mortality, they used the full MACE definition, MI, stroke, or death.
And the result there.
Tirzepatide also came out ahead. It showed a reduced risk of MCE compared to dulaglutide. The hazard ratio was 0.87.
Okay, so maybe slightly less pronounced than SEMA versus sitagliptin, but still showing benefit against an active drug.
Exactly. It basically solidified the evidence that tirzepatide provides cardiovascular benefit in these broader populations too. So, step 1 confirmed. Both drugs are effective in the real world against older standards.
Which, of course, leads us directly to the main event, the head-to-head. This is what everyone's been wondering about. Almost 300,000 patients starting one or the other. Tirzepatide versus semaglutide. What did they find for the primary MACE outcome? MI, stroke, or death?
Well, the answer from this massive real-world data set was pretty clear. Parity. The actual one-year risk was identical, 1.3% for those starting tirzepatide and 1.3% for those starting semaglutide.
Wow, exactly the same. Okay, but what about the statistics, the hazard ratio? Any hint of an advantage one way or the other?
The head-to-head hazard ratio, comparing tirzepatide to semaglutide, was 1.06. Now, crucially, you have to look at the confidence interval around that number, and that interval stretched from 0.95 to 1.18. Since it comfortably crosses 1.0, which means no difference. The statistical conclusion is clear. There was no significant difference between tirzepatide and semaglutide in reducing major adverse cardiovascular events in this real-world setting.
So, bottom line for a clinician, or for you listening, trying to decide based purely on MCE prevention, this study suggests they're basically comparable.
That's the main message for MC. The benefits are similar. If anything, the point estimate of 1.06 slightly favored semaglutide numerically, but again, not statistically significant. It's within the bounds of random chance.
And did this hold true even for the sickest patients, the ones with the highest cardiovascular risk?
Yes, they looked specifically at that subgroup, and the results are consistent. The hazard ratio was 1.11, again with a confidence interval crossing 1. So even in the highest risk group, the MCE benefits appeared comparable.
Okay, so parity on the main MCE outcome. But you mentioned secondary outcomes earlier. Was there anything else that hinted at a potential difference? Something around heart failure?
There was a subtle finding there, yes. They looked at a composite outcome specifically for heart failure, things like being hospitalized for heart failure, needing an urgent visit, or death related to it. And when comparing tirzepatide versus semaglutide for that outcome, the hazard ratio was 0.91.
0.91. So that point estimate suggests maybe a slight edge for tirzepatide on heart failure.
It does suggest that, numerically.
Yeah.
But again, the caution. The confidence interval still crossed 1.0. It was 0.81 to 1.01. So we can't definitively say tirzepatide is better for heart failure based on this. It's more of a suggestion, a potential signal.
Interesting. And tirzepatide is the one with the dual GIP and GLP-1 action. Could that GIP component be the reason for that potential hint of a heart failure benefit?
That's the leading theory right now. We know GLP-1 is great for MACE. The GIP part, well, its cardiovascular role is still being figured out. But tirzepatide often leads to more significant weight loss than semaglutide alone, and many think the GIP action drives that extra weight loss. So the hypothesis is that maybe this more pronounced weight reduction, thanks to GIP, is what's driving that potential modest numeric advantage, specifically for heart failure outcomes. More weight loss often helps heart failure.
So GIP's role is still a bit murky overall in heart health.
Very much so. Honestly, the research is limited and even points in different directions sometimes. Some hints at protection, some hints at maybe inflammation. This study adds a piece to the puzzle, suggesting a potential positive link via weight loss for heart failure. But it definitely tells us we need more research focused specifically on GIP's cardiovascular biology.
Makes sense. And quickly, any safety differences pop up in the head-to-head? GI side effects, infections?
Nothing major stood out. Gastrointestinal issues, which you expect with these drugs, were pretty similar between the two groups. They also saw lower risks for serious bacterial infections compared to the older drugs they were benchmarked against. And remember those negative controls they used? Things like hernia surgery rates.
Right. Things the drug shouldn't affect.
Exactly. And they found no association, which just adds another layer of confidence that the main findings on heart outcomes are likely real and not just some artifact of the data or method. Okay, so let's pull it all together. What's the core takeaway for clinical practice? I think it's this. This large, careful, real-world study first validated its methods against RCTs. It then confirmed that both semaglutide and tirzepatide provide strong, real-world cardiovascular benefits compared to older treatments in broad populations. And maybe most importantly, when put head-to-head, these two powerful drugs showed remarkably similar effectiveness in reducing the major cardiovascular events that we worry most about: heart attack, stroke, and death.
Yeah, and for you, the listener trying to stay on top of this rapidly changing field, this kind of study is incredibly valuable, isn't it? It gives us timely answers, or at least strong evidence, to fill gaps left by the absence of head-to-head RCTs. It helps bridge that gap between innovation and knowing how to use these tools confidently in practice, showing parity on MACE protection.
Absolutely. Which brings us to a final thought, maybe a bit provocative. This study showed just how robust, well-designed real-world evidence can be, especially when it successfully benchmarks against reference trials like SUSTAIN-6 and SURPASS-CVOT. It raises a really important question, I think. In fields like this, moving so quickly, does the traditional requirement for, say, two huge, expensive, time-consuming confirmatory RCTs for every single new use of a drug still make sense? Especially when rigorous RWE, like we saw here, can potentially provide strong, complementary, and much faster evidence to get life-saving treatments evaluated and potentially approved for the patients who stand to benefit.
That's a fascinating question for the future of drug development and regulation. Something for all of us to think about as these cardiometabolic therapies continue to evolve at lightning speed.